Welcome back to Oral Medicine Simplified. In the previous lecture, we focused on classical trigeminal neuralgia, the electric shock like facial pain that every dentist must recognize before performing irreversible dental treatments. Today, we are going beyond classical trigeminal neuralgia because nerve related facial pain does not always follow the same pattern and it does not always come from the trigeminal nerve alone. Some patients present with pain in the throat and ear. Some develop persistent burning pain after shingles. Some experience numbness and burning after extraction, implant placement, injection, or surgery. And some patients have a burning mouth even when the oral mucosa looks completely normal. So, the purpose of this lecture is not simply to memorize names. The purpose is to train your clinical eye to recognize nerve-related pain pattern before labeling the pain as dental. A patient may come to the dental clinic pointing towards the jaw, the posterior teeth, the tongue, or even the ear, and naturally, both the patient and the clinician may begin by thinking of a dental cause. But facial pain often behaves differently from ordinary dental pain. The site where the patient feels pain is not always the site where the problem begins. Pain may be referred, it may follow a nerve distribution, it may remain after the original tissue injury has healed, and sometimes the oral tissues may look completely normal while the patient is experiencing very real neuropathic pain. That is why one of the most important lessons in facial pain is this: do not diagnose only from the location of pain, diagnose from the pattern of the pain. Before we discuss individual conditions, we need a simple clinical distinction, which is neuralgia versus neuropathy. Neuralgia usually means brief attacks of pain along the nerve. The patient often describes it as electric, shooting, stabbing, or lightning like. The attack may be triggered by something very ordinary, like swallowing, touching, chewing, brushing, talking, or yawning. Neuropathy is different. In neuropathy, the nerve is damaged or dysfunctional. The pain is often more continuous, burning, more tingling, or associated with numbness and altered sensation. So, when you hear sudden electric shock, you need to think about neuralgia. And when you hear burning, numbness, tingling, hypersensitivity, you need to think about neuropathic pain. This distinction will guide the rest of the lecture. By the end of this lecture, you should be able to recognize the clinical picture of glossopharyngeal neuralgia, especially when the pain is triggered by swallowing and radiates towards the ear. You should also be able to separate neuralgia from neuropathy because these two words are often used casually, but clinically they represent different patterns of pain. We'll then discuss post-herpetic trigeminal pain, the persistent neuropathic pain that may follow shingles, and post-traumatic trigeminal neuropathy, which is especially important in dentistry because it may occur after procedures involving the trigeminal nerve branches. Finally, we'll approach burning oral pain systematically so that burning mouth syndrome is considered responsibly after excluding local and systematic causes, not by dismissing the patient. Let us sharpen the distinction further. In neuralgia, the nerve behaves like a trigger wire. The patient may be pain-free between the attacks, but a small stimulus can suddenly provoke a severe shock-like episode. The duration is usually short, from seconds to a couple of minutes, but the intensity can be extreme. In neuropathy, the problem is not just a trigger. The nerve itself has undergone injury or dysfunction. The patient may have ongoing burning, pins and needles experience, squeezing, altered sensation, or numbness. Brief shocks may still occur, but they are not usually the main pattern. So, clinically, we are not just asking where is the pain, we are asking how does the pain behave. That question often gives more diagnostic information than the radiograph. Dentists are frequently the first professionals to see facial pain patients. This makes sense because patients often interpret pain in the jaw, teeth, gums, tongue, or face as a dental problem. But facial pain is not always odontogenic. A patient may sit in a dental chair with normal teeth, normal periodontal tissues, and no radiographic cause, yet still have severe pain from a nerve related disorder. This is why facial pain requires a disciplined history. You need to ask about the quality, duration, triggers, distribution, previous procedures, previous infections, sensory changes, and red flags. So, before treating the tooth, understand the pain. That single pause can prevent unnecessary root canal treatment, extraction, repeated antibiotics, and patient frustration. Before moving forward, let us briefly revisit trigeminal neuralgia. The classical trigeminal neuralgia usually affects one side of the face and follows one or more divisions of the trigeminal nerve V1, V2 or V3. In dentistry, V2 and V3 are especially important because pain in these divisions can mimic maxillary or mandibular toothache. The pain is typically electric shock-like, severe, brief, and triggered by light stimuli such as touching the face, chewing, brushing, shaving, speaking, or even a breeze. This recap matters because today's lecture builds on this data. We are now asking what other nerve-related facial pains can resemble dental pain, and how do we recognize them before treating the wrong structure. Now we move beyond classical trigeminal neuralgia. The first route is the glossopharyngeal neuralgia, a rare but important condition where pain may be felt in the throat, tonsillar region, posterior tongue, ear, or angle of the jaw. Second is post-herpetic trigeminal pain, where pain persists after shingles has affected a branch of the trigeminal nerve. The third is post-traumatic trigeminal neuropathy, which is highly relevant to dental practice because it may follow an extraction, implant placement, local anesthesia, endodontic complications, or oral surgery. And the fourth is burning neuropathic oral pain, including burning mouth syndrome, where the patient's pain is real even though the mucosa may appear normal. Glossopharyngeal neuralgia is sometimes called the forgotten neuralgia because it is far less commonly discussed than trigeminal neuralgia, yet it can be very confusing clinically. The glossopharyngeal nerve, which is the cranial nerve 9, carries sensory information from areas such as the posterior third of the tongue, tonsillar region, pharynx, and related areas that may refer pain towards the ear and angle of the jaw. So, the patient may not describe it as nerve pain. They may say that I have severe pain in my throat, pain deep near my ear, pain near the back of my tongue, or pain near the jaw angle. If we do not know this pattern, the patient may be misdirected towards dental, ENT, or even repeated antibiotic treatment without addressing the real issue. The most important clinical clue in glossopharyngeal neuralgia is the trigger. The pain is usually unilateral, sudden, severe, stabbing, shooting, or electric. It often lasts only seconds to 2 minutes. But what makes it memorable is that attacks may be provoked by swallowing, coughing, talking, chewing, or yawning. So, when a patient says that every time I swallow, a sharp electric pain shoots from my throat to my ear, that sentence should immediately alert you. This is not the usual behavior of pulpitis. It is not the usual behavior of pericoronitis. It is not simply a sore throat. It is a nerve pattern history, and the clinician must recognize it. Here's where the dentist can get trapped because the pain may be felt near the posterior mandible, the angle of the jaw, the ear, or the tonsillar region. The patient may believe that the wisdom tooth or posterior molar is responsible. But in glossopharyngeal neuralgia, the teeth may be normal. The radiograph may not explain the pain. Pulp testing may be normal. There may be no swelling, no sinus tract, no periodontal abscess, and no clear odontogenic pathology. The key is the mismatch. Dramatic electric pain triggered by swallowing with normal dental findings. When you see that mismatch, do not force a dental diagnosis. Step back and reconsider the nerve pathway. But even when a pain pattern sounds neuralgic, we must never ignore the red flags. Glossopharyngeal neuralgia can rarely be associated with vagal symptoms such as fainting or bradycardia. That means a patient will be reporting to you with throat to ear pain with symptoms such as collapse, dizziness, or cardiac symptoms, and these deserve urgent medical attention. Other red flags are equally important, such as dysphagia, hoarseness, unexplained weight loss, a neck mass, ulceration, progressive neurological signs, or persistent unilateral symptoms that do not fit a benign pattern. As oral medicine clinicians, we must balance pattern recognition with safety. Neuralgia is a clinical possibility, but red flags demand investigation. A dangerous lesion, malignancy, deep infection, or neurological disorder must not be missed. For the dental clinician, the management principle is simple: recognize, document, and refer. Recognize the pattern by listening carefully to the history. Document exact pain quality, duration, trigger, distribution, dental findings, and any red flags. Then refer appropriately to oral medicine, neurology, ENT, or maxillofacial specialist. This depends on the presentation. The most important thing is to avoid irreversible dental treatment. When the dental diagnosis is weak, do not extract simply because the patient is in pain. Pain alone is not an indication for extraction. The diagnosis must justify your treatment. So, in suspected glossopharyngeal neuralgia, the correct professional response is not aggressive dental treatment. It is careful recognition and timely referral. Now let us move to post-herpetic trigeminal pain. Herpes zoster, which is commonly known as shingles, occurs when varicella zoster virus reactivates. If it affects the trigeminal nerve, the patient may initially develop a painful unilateral rash in the distribution of V1, V2, or V3. But even after the rash heals, the nerve may remain sensitized or damaged. The patient may continue to experience pain in the same distribution. This is why post-herpetic trigeminal pain is not just a skin problem, it is a neuropathic pain condition. The visible rash may fade, but the nerve pain may persist. The clinical clues are usually found in the patient's history. The pain may be burning, stabbing, tingling, itching, crawling, or hypersensitive. A light touch may feel painful. Washing the face, brushing teeth, chewing, or touching the skin may become uncomfortable. The distribution is also very important. The pain usually follows the same side and the same trigeminal branch that was affected during shingles. So, if the patient has a history of unilateral shingles and now complains of burning, hypersensitive facial or oral pain in the same region, that history is the clue. The mouth or teeth may be painful, but the underlying problem may be post-herpetic nerve injury rather than pulpitis or periodontal disease. This is another common dental trap. After shingles, a patient may complain of pain in the upper teeth, lower teeth, gingiva, palate, or jaw. If a dentist sees an old restoration, mild periodontal change, or a questionable radiographic finding, it may be tempting to treat the tooth. But we must ask, does the dental finding truly explain this pain? Post-herpetic pain is often burning and hypersensitive. It may follow a nerve distribution. It may occur after a clearly documented unilateral rash. It may be provoked by touch rather than by classic pulpal thermal stimuli. So, the warning is clear. Avoid unnecessary root canal treatment or extractions unless there is independent, convincing dental pathology. For post-herpetic trigeminal pain, the clinician's role is to recognize the neuropathic pattern and protect the patient from unnecessary procedures. The pathway is recognize the history and pain quality, avoid irreversible dental treatments and procedures when the dental evidence is weak, and refer or manage appropriately. Patients may need medical management for neuropathic pain, and they may require collaboration between oral medicine, neurology, pain medicine, ophthalmology if V1 is involved, or their primary physician. A helpful way to explain it to the patient is that the infection has healed, but your nerve has not healed completely and it may still be sending pain signals. That explanation validates the patient's symptoms without falsely blaming the tooth. Now we come to a condition especially relevant to dentistry: post-traumatic trigeminal neuropathy. This occurs when patient develops pain after an identifiable injury to a trigeminal nerve branch. In dental practice, this may follow third molar extraction, implant placement, local anesthesia, endodontic over-instrumentation, surgical trauma, fractures, or other procedures close to the inferior alveolar, lingual, mental, infraorbital, or other trigeminal branches. The mandibular division is particularly important because the inferior alveolar nerve and mental nerve are closely related to common dental procedures. The key feature is not just pain after a procedure. The key feature is pain plus evidence of altered nerve function. Patients rarely come in using the term neuropathy. They describe what they feel. They may say that my lip feels numb or painful, my chin burns, my tongue feels strange, my gums feel altered, it burns after the extraction, even light touch hurts. These all descriptions are very important. Numbness, tingling, altered sensation, burning, hypersensitivity, and pain from light touch all point towards nerve dysfunction. Ordinary postoperative pain should gradually improve as tissues heal, but neuropathic pain may persist even when the socket has healed and the tissues look normal. So, listen closely to the patient's language. It often contains the diagnosis. When post-traumatic trigeminal neuropathy is suspected, sensory testing is not optional. It is a part of examination now. Compare the affected and the unaffected sides. Test light touch gently. Ask whether the sensation is reduced, exaggerated, unpleasant, burning, or painful. Map the area carefully: lower lip, chin, tongue, gingiva, palate, or facial skin, depending on the nerve involvement. Look for numbness, allodynia, altered sensation, hyperalgesia. These all signs help distinguish neuropathic pain from ordinary dental or post-surgical pain. Also document everything clearly: onset, procedure history, distribution, sensory findings, pain quality, and functional impact. In nerve injury cases, careful documentation is clinically important and medico-legally important. This slide captures one of the most damaging cycles in facial pain. A patient has persistent pain and a tooth is extracted. The pain continues, then root canal treatment is attempted. Then antibiotics are prescribed. Then occlusion is adjusted. But the pain remains because the underlying nerve injury has never been recognized. This is how patients become trapped in repeated treatment. Neuropathic pain does not resolve simply because we keep treating teeth. In fact, repeated procedures may increase distress, reinforce fear, and sometimes worsen sensitization. So, when pain persists, despite healing of the tissues and weak dental findings, pause, reassess, and ask whether the nerve is involved or the tooth is involved. What is the source of the pain? The goal is not to do more. The goal is to diagnose better. Now let us discuss burning oral pain. Patients may describe it very vividly. They may say that it feels like hot tea burned my mouth. My tongue burns, my palate burns, my lips burn, or my whole mouth feels irritated. Burning pain may involve the tongue, palate, lips, or multiple oral sites. Sometimes there is an obvious local cause, sometimes there is a systemic cause, and sometimes the mucosa looks completely normal. The mistake is to assume that normal appearance means that the patient has no real problem. Burning pain can be neuropathic, inflammatory, dryness related, deficiency related, medication related, endocrine related, or multifactorial. So, it deserves a structured clinical approach. Burning mouth syndrome is one of the most misunderstood diagnoses in oral medicine. It does not mean the patient is imagining it. It also does not mean we could not find anything. So let us call it BMS. Burning mouth syndrome refers to a chronic burning or dysesthetic oral pain, typically with normal appearing mucosa, after other local and systemic causes have been excluded. That distinction is essential. The mucosa may look normal, but the pain is real. At the same time, before diagnosing BMS, we must exclude conditions such as candidiasis, xerostomia, lichen planus, trauma, nutritional deficiency, anemia, diabetes, thyroid disease, medication-related dryness, and other relevant causes. A systematic approach prevents both overdiagnosis and underdiagnosis. First, examine the mucosa carefully. Look for candidiasis, erythema, ulceration, erosive lichen planus, trauma, denture irritation, geographic tongue, dryness, and local irritants. Then, review the medical history. Ask about diabetes, thyroid disease, anemia, menopause related symptoms, medications, anxiety, depression, reflux, autoimmune disease, and dry mouth symptoms. Third, investigate the common causes, such as the blood tests may include CBC, iron studies, vitamin B12, folate, glucose or HbA1c, thyroid profile, and other tests depending on the case. Fourth, if clinical examination and investigations do not reveal an explanatory cause, then and only then burning mouth syndrome can be considered. That is responsible oral medicine. Now let us compare dental pain and nerve pain more directly. Dental pain often has a dental logic. There may be thermal sensitivity, biting pain, swelling, tenderness, periodontal pathology, caries, pulpal involvement, or a radiographic cause that matches the symptoms. Nerve pain often has a nerve logic. It may be electric, burning, tingling, there may be numbness, it may be triggered by something, there may be trigger zones. The symptoms may be severe while dental findings are minimal or unrelated. The important lesson is not that the dental pain is unimportant. Dental pain is extremely common, but when the story does not match the teeth, do not force the diagnosis. A good clinician respects both patient's pain and the biology of the disease. So when you suspect nerve-related facial pain, use a structured algorithm. Start with the pain story. Let the patient describe it fully. Then clarify the quality. Is it electric, burning, stabbing, throbbing, pressure-like, or tingling? Ask about duration. Does it last seconds, minutes, hours, or all day? Ask about triggers. Is it provoked by touch, chewing, swallowing, brushing, cold, heat, or is it spontaneous? Map the distribution. Check for sensory change. Then rule out dental and oral diseases through proper examination and relevant investigations. Next, actively look for red flags. If the diagnosis is uncertain, avoid irreversible dental treatment. Finally, refer when the pattern suggests neuralgia, neuropathy, malignancy, neurological disease, or complex facial pain. This algorithm is how we reduce diagnostic error. Let us apply the pattern. A 58-year-old patient presents with sudden stabbing throat pain radiating to the ear. It is triggered by swallowing and yawning, and the dental examination is normal. Now you ask yourself, does this sound like pulpal pain? Does it sound like periapical infection? Does it sound like periodontal abscess? The answer is no. The key features are throat to ear radiation, swallowing trigger, sudden stabbing quality, and normal dental findings. At this point, the diagnosis is not confirmed yet, but the pattern is strongly suggested of Glossopharyngeal neuralgia. The correct response is to recognize the pattern, check for red flags, document, and refer appropriately. Here's the second case. A patient reports pain 4 months after mandibular third molar extraction. The socket has healed normally, but the lower lip and chin feel numb, burning, and hypersensitive. This is not ordinary post extraction pain. Ordinary surgical pain should improve as healing occurs. Here, the presence of numbness and hypersensitivity tells us that the sensory nerve pathway may be involved. The affected region is the lower lip and chin. They also point towards the mental nerve or inferior alveolar nerve distribution. So, the likely pattern is painful post-traumatic trigeminal neuropathy. The next step is sensory testing, mapping, documentation, explanation, and referral or specialist management. Now consider the third case. A patient has daily burning tongue pain. The tongue and oral mucosa look normal. There is no ulcer, no candidiasis, and no obvious trauma. This is where clinical maturity is important. We should not say that everything is normal, so there is nothing wrong. But we should also not immediately diagnose burning mouth syndrome without evaluation. Before diagnosis, we must exclude common local and systemic causes such as candidiasis, xerostomia, mucosal disease, nutritional deficiencies, anemia, diabetes, thyroid disease, medication-related dryness, trauma, parafunction, and other relevant factors. Only after exclusion does burning mouth syndrome become a responsible diagnostic consideration. Let us summarize the mistakes that commonly lead to poor outcomes. The first is assuming that all facial pain is dental. The second is extracting teeth without a strong diagnosis. The third is prescribing repeated antibiotics when there is no infection. The fourth is ignoring numbness, tingling, or altered sensation, which may be the most important clue to nerve dysfunction. The fifth is dismissing burning pain simply because the mucosa appears normal. And the sixth is missing red flags such as dysphagia, hoarseness, weight loss, neck mass, ulceration, fainting, or neurological signs. Good oral medicine is not just about treating lesions, it is about interpreting symptoms safely and intelligently. So, to summarize it all, glossopharyngeal neuralgia should come to mind when there are swallow-triggered throat-to-ear electric or stabbing pains. Post-herpetic trigeminal pain should be considered when burning hypersensitive pain persists after shingles in the same trigeminal distribution. Post-traumatic trigeminal neuropathy should be suspected when pain occurs after a nerve-related injury or dental procedure and is accompanied by numbness, tingling, allodynia, hyperalgesia, or sensory change. Burning mouth syndrome should be considered when burning oral pain persists with normal appearing mucosa, but only after local and systemic causes have been excluded. The common thread is pattern recognition. When the pain behaves like nerve pain, do not treat it as ordinary dental disease. I want to end this with this line. Do not extract the tooth when the nerve is crying for diagnosis. This is not just a memorable quote, it is a clinical responsibility. Many facial pain patients suffer not only from pain but also from delayed diagnosis and unnecessary procedures. The site of pain is not always the source of the pain. A tooth may be innocent, a nerve may be injured, a normal looking mouth may still be painful. As dental professionals and oral medicine clinicians, our role is to listen deeply, examine carefully, recognize the patterns, respect the red flags, and choose referral when the case requires it. Thank you for watching Oral Medicine Simplified. I am Dr. Suman Saeed, and follow Oral Medicine Simplified so that you keep learning, keep questioning the pain pattern, and always diagnose before you treat.